Um, with that, I'd like to move on and introduce Dr. Namrata Chandak, who's an assistant professor at the Sylvester Comprehensive Cancer Center at University of Miami, to discuss lower risk myelodysplastic syndromes. Dr. Chandak?
Good morning, and thank you for that introduction. I am just trying to turn my camera back on. There we go. Well, thank you for the wonderful opportunity to talk today. My name is Namrata Chandok, and I am an assistant professor of clinical medicine at Sylvester Comprehensive Cancer Center. And today I'm going to talk to you about low-risk MDS. So just a quick presentation roadmap. We're first going to talk about the diagnosis of MDS, as followed by risk stratification and how we differentiate between higher risk and lower risk MDS, as this makes a difference in terms of what type of therapies we're offering. Following that, we'll talk about the therapeutic goals that are particular to lower risk MDS and the current treatment algorithm for these patients. Finally, we'll focus a little bit more on providing equitable and inclusive care and what that means, particularly in this population, from diagnosis to treatment, and identify some of the challenges from a patient perspective or a provider perspective as well. So the diagnosis of MDS is basically an umbrella diagnosis that includes a group of clonal myeloid neoplasms that are characterized by cytopenias and ineffective hematopoiesis, which then leads to abnormal blood and bone marrow morphology. From a patient perspective, what this means is that these patients have low cell counts with anemia, thrombocytopenia, or neutropenia, which can have particular effects on their life. In addition to that, it also predisposes patients to progression to AML with certain subtypes more than others and at higher risk. So to make this diagnosis, beyond having cytopenias and a history and physical, we usually have a bone marrow biopsy where we assess the morphology. But in more recent times, as science has evolved, we've learned a lot of other things are important, including molecular data as well as cytogenetic data. So these are all key components in the diagnosis and risk stratification of patients of MDS. And with all of this data in mind, we can make important prognostic and treatment decisions that we further discuss with the patient thereafter. So in terms of risk stratification, when a patient comes into the office the first time, we're basically trying to figure out what their risk is to progress to AML and how we expect their life to be. And one of the ways to do this is using the International Prognostic Scoring System, or the IPSSR. This score has evolved over time, starting from the IPSS, where there were three key components that were monitored: blast percentage, the cytogenetics that we mentioned, and then the number of cytopenias. And based on this information, patients were divided into 4 categories or risk groups. With the development of the IPSS-R, blast percentage was still considered, but in addition to this, the cytogenetics were further refined into 5 different categories, and weights were changed for particular cytopenias, so focusing on hemoglobin, platelet count, and neutrophil count separately. And in this scoring system, basically it was subdivided into 5 categories or risk groups. The most recent iteration of this is the IPSS-M, which takes into account all the prior subsets, but also accounts for 31 individual genetic mutations and creates a treatment algorithm, so further substratifies patients. And we've learned a lot about this in the last couple of years, and a lot more is to come at the annual ASH meeting that's upcoming in terms of real world experience with this data. Once we have this information, we basically can break patients into two major buckets: lower risk disease and higher risk disease. And why this is important is because the goals of treatment are different in both these subsets. In lower risk disease, as you see, and as you progress down that spectrum, what's happening is that your bone marrow function is declining. You have changes in differentiation, and apoptosis of abnormal cells is declining. And when you move closer to that higher risk AML side of the spectrum, you're having greater cellular proliferation of abnormal cell types, increasing transfusion requirements, and greater immune suppression. So the therapeutic goals in lower risk MDS vary because lower risk MDS patients tend to survive longer, have long-term, more chronic medical needs. So in this situation, the key factors that need to be considered are establishing an appropriate monitoring plan, decreasing their transfusion needs because the primary issues these patients experience are related to their cytopenias, decreasing the impact on quality of life. And a major evaluation over the past several years is determining how patients do with MDS. You know, patients with MDS tend to have more comorbidities, report depression, fatigue, and many things that can hinder quality. So the focus is to improve quality. And then also to lower the risk of transformation to AML and maximize their clinical benefit for as long as possible. And a big part of this is discussing this upfront with the patient and having expectation management. As a generally palliative disease, primarily because most patients are older, which we'll discuss on a later slide, the treatment goals may be varied too, depending on how old the patient is and their other comorbidities. So how do we actually treat these patients? The most common cytopenia that's associated with MDS is anemia. And management of anemia varies depending on some of those factors we discussed. So for many patients, erythropoietin stimulating agents are the first line of therapy when they are lower risk disease or with an IPSS-R score of less than 3.5. This is particular if their anemia is more pronounced or symptomatic. And patients, depending on their erythropoietin level and several other factors, may or may not respond to this, but that's usually the first line of therapy. There are certain subgroups, such as patients with mutant SF3B1 or ring sideroblasts, or patients with an isolated deletion 5q, which can derive particular benefits from two other agents, luspatercept and lenalidomide particularly. So luspatercept, the primary data was based on the MEDALIST trial, which was a study that compared luspatercept to placebo in transfusion-dependent low-risk MDS patients with either 15% ring sideroblasts or 5% ring sideroblasts with an SF3B1 mutation that was refractory or unlikely to respond to an ESA. And in this subpopulation, approximately half of all patients in the luspatercept arm had a hematologic improvement compared to 12% in the placebo arm. And transfusion independence was achieved in 38% compared to 13% in the placebo arm, with a median of 30.6 weeks in the luspatercept arm compared to 13.6 in the placebo arm. In patients with isolated 5q, the data actually first evolved from an unselected MDS population. And in that initial study, they noticed that patients with an isolated deletion of the long arm of chromosome 5 had particular benefit, where more than half of the patients had transfusion independence, and transfusion independence for a significant amount of time. So 2.2 years was the median duration of response. While you can also have responses in a non-DELQ mutation population, they're much more modest. And beyond just the treatments that we can offer, red cell transfusions tend to be the mainstay of supportive care in this population. In addition to that, patients who have thrombocytopenia may benefit from thrombopoietin agonists and platelet transfusions, which, as many of you as providers may know, are extremely difficult because they require frequent transfusions. And then in the case of neutropenia, there isn't a particular drug or agent that is necessary because G-CSF has not proven to have an overall survival benefit overall. But in select patients with infectious complications, antimicrobial prophylaxis is appropriate. Finally, in patients with multi-lineage dysplasia, depending on other subcharacteristics, treatments such as ATG and cyclosporin, particularly in the hypoplastic MDS population, and hypomethylating agents with other low risk but evolving to higher risk disease may be of benefit, and different regimens or treatment schedules have been studied and established on this. Now, patients who progress with this generally end up moving to treatment or management plans more similar to higher risk MDS. And in select patient populations, transplant may also be an option down the line. So what are the barriers limiting standard of care therapy these days? These generally include diagnostic barriers. So inability to get all the standard testing. As we mentioned, the bone marrow biopsy is a standard test, but also now we've added on mutations as we're tailoring a lot of treatments based on mutations. And then access to providers who can appropriately risk stratify and plan based on these treatments that we just discussed. With less experienced providers, more so, and perhaps even with, seasoned providers, there's definitely a physician bias based on our personal opinions, which I will share with you. And then also for certain subpopulations, more trust in the medical establishment, particularly when we're discussing clinical trials and further therapy. So I just wanted to throw in a few facts from AAMDS, and they had done a very nice survey with where there were 157 respondents. And out of this, 61% basically said that they had encountered obstacles in diagnosis and treatment. And these obstacles included lack of provider experience, like I just mentioned, lack of information about their condition, perhaps because they weren't, seeing the right patient providers, or just it was not provided in a format that was accessible to them, and then delay in referral to a specialist. And the factors I'm going to touch on a little bit right now are that limit appropriate care include age, finances, geography, and briefly as well, ethnic and racial bias as well. So age is a big factor in MDS, primarily because most of our patients with MDS are older. The incidence of MDS significantly increases with age, and the median age of diagnosis is 77 years. With every decade of life, the percentage actually goes up, and the incidence rate for patients younger than 40 is 0.1 cases per 100,000 person years. But when you go up to patients over the age of 50, 80, it is 56% roughly out of 100,000. So it's a significant increase in the second half of life. And a fact about our general population is that the US population is aging. So we're expecting that we will see more patients with these disorders, particularly given that we have a bigger, older population. A sad fact in this whole process is that many patients with MDS are underdiagnosed because older patients are not frequently evaluated appropriately for their anemias. Anemias independently can cause a lot of significant changes, such as falls, fatigue, fragility overall, sarcopenia, which has been studied extensively, and then cognitive decline, which lead to progression or worse, decline in some way. But specifically with that MDS population, what I can tell you is that anemia in older people was looked at by several larger studies, and about 30 to 50% of patients were not even evaluated, primarily just because they were elderly. And then in one study, they actually said that patients were, suspicious for MDS in 16% of the population, but no further evaluation was done. So obviously we are not serving these people well because they're going to develop complications of their disease and anemias overall. The second thing just to touch on briefly is financial toxicity. So these were just quotes that I pulled from the AAMDS survey, which were reflective of this mission or, this hardship on patients. But, healthcare providers not being able to have the tools for the diagnosis, not being able to meet the appropriate care. This one person who mentioned that the dose of medication that they were on was $125,000 per year. These are all barriers for a vast majority of the US population, as well as outside of this country. In addition to that, this is a stressor on all parts of the family, which leads to general hardship, overall financial distress, and a lower sense of well-being, primarily because both subjectively, but also, patients skipping medications because they can't afford them and therefore having inadequate health, which then snowballs into a greater risk of mortality. Now, skipping over to provider bias. This was a very interesting and enlightening fact I learned, and I'm just going to highlight the two big things here. But some providers often overestimate the burden of certain specific therapies when it comes to patients. So I will show you in a second that, patients often are given less treatment and made more transfusion dependent, or given more transfusion and supportive care because the provider might think that treatment is difficult. But here, when you look at the physician statement, getting treatment is easy. Physicians said that only 21% of the time, whereas 51% of the patients said treatment wasn't really as much of an impairment on their life as they thought it would be. Similarly, this was looked in both physicians as well as non-physician healthcare providers. So, the sentiment is the same. So we really have to be on the same page with our patients when we're discussing care. And this basically translates to patient not necessarily getting the best therapies or the most therapy that they would benefit from. As you can see here, a lot of patients who got ESAs or erythroid stimulating agents up front did not get second-line therapy or a third-line therapy, or were not evaluated for things like hypomethylating agents, which, like we say is our standard of care for all of these patients. So even if we're just optimizing what's already available, which is quite limited, we could do a better job. Now, when it comes to race and ethnicity, I'm sure we will be talking much more about this. But what was interesting to me is in the AAMDS survey, as you can see, 86% of respondents were Caucasian Americans. And this isn't really, or Caucasian patients overall, not Americans. This isn't really reflective of our patient population at large anymore, or the demographics of the United States. So where is this inequity born, or where is the access? Where are the fault lines in access? So I think it starts all the way back from target development. And this starts where you're looking at multi-omic studies, and most of those targets are developed based on scientific data or basic science data coming from European descendant patients. And then when you move forward to trial enrollment, there was a large evaluation of all the trials on clinicaltrial.gov. And from the 230 trials that were evaluated on study, Black and Hispanic patients were underrepresented compared to the expected proportion in many of these studies. So this sort of creates a spiral moving forward with drug approval. And then when drugs are actually approved and go forward, combination therapies are also all dependent on that same initial population that we have been evaluating throughout. And what's sad to know is that even at present, data collection of race and ethnicity related data was only seen in about 2/3 of trials that are currently accruing as of 2 years ago. So this creates a never-ending loop in terms of providing less good care for our diverse populations ethnically and racially, and something that we need to talk about and try and fix moving forward, which we will speak about further during this seminar. And a recent study that was published earlier this year actually showed one of the reasons for this is access to care. So they, as you can see in these figures, the areas where you have the clinical trials are highlighted in red, but the amount of time patients had to drive to get to any of these sites where they could get to a center of excellence within 30 minutes was in the light blue, and within 60 minutes was, the darker blue in the little margins. So you can see large swaths of the country that are completely underserved. And primarily these underserved areas are where minority populations live. So if you look on the figure on the right side, that is not MDS specific, that's about AML mortality and AML minority representation. The blue dots are clinical trial frequency. So they are much more highly available in places where Black minorities or even Indigenous Americans are not living, or even the Hispanics, which are represented in green. So to fix this, we have a lot of issues to work with right now. And this is again going back to that AAMDS survey. It kind of reflects all the same problems I've been talking about from the clinical literature. So lack of experience, delayed to referral, financial issues. But these are all things worth considering when we're trying to make our patients' lives better. With that, I'd like to thank you for your attention, and I'm sure we'll have a fruitful discussion after. Thank you.
Thank you so much, Dr. Chandak. That was both educational and provocative. It's amazing to review some of those statistics, and I guess to wonder, and I guess we can talk about this during our panel discussion, whether this is something specific to bone marrow failure conditions, or is this reflective of medical care in the country as a whole, or medical care within people who have cancer as a whole. We'd like to open this up for any questions for Dr. Chandak, and the question session will be moderated by Alice Hauk from the Aplastic Anemia and MDS International Foundation. Alice?
Hi there. We have no questions coming in, but we receive questions from patients and providers as well, with the issue of discussing treatment options for patients, and especially with if age is a consideration sometimes, especially with providers who may not see many patients, many MDS patients, and if there are just some biases that might be coming through with providers who may not be giving the full range of treatment options to patients. Is that an issue that you and Dr. Chandak see?
Absolutely. I think one of the things that we definitely see are either patients who have not been offered all the options, not even clinical trial standard of care, primarily because they were thought to be too weak or too fragile for therapy. We are very cognizant of the fact that we are only seeing a tiny subset that have access to our care in a major metropolitan center with insurance and so, but this definitely is the case. And there are many things that I did not go into in particular, but age also brings many comorbidities. Like I mentioned, MDS patients have more comorbidities than your age match counterpart. And oftentimes trial enrollment is limited because of such comorbidities, such as, renal function. And Dr. Sekaras actually did a wonderful study about this, where, they did trial-based therapies off trial and showed that there were no differences. So perhaps something we can discuss further is liberalizing treatment to patients who may benefit. But I'll let Dr. Sekaras talk about that.
Well, I wanted to focus on, there was a study that was conducted a few years ago, and it was through the Aplastic Anemia and MDS Foundation, and it was actually led by Aaron Gerds before he terminally differentiated to focus more on myeloproliferative neoplasms. And I always show this slide. It was an abstract at ASH where the survey looked at perceived side effects that led to stopping therapy. And it questioned both patients and providers. And providers came up with these percentages 90% said I stopped this therapy because my patients couldn't tolerate it. And 70% said the side effects that my patients were experiencing prohibited me from continuing this therapy or forced me to lower the dose. And it was all about these toxicities. And then when the same questions were asked to patients, so did side effects lead to discontinuation of therapy, only 1/3 of the time did patients say yes. So it was literally a doubling of percentages for when practitioners were saying that side effects impacted therapy and caused them to stop versus when patients perceived that side effects were the cause of stopping therapy. And I've always interpreted those data as meaning that probably as providers, we're probably stopping therapy because we're saying that patients can't tolerate it anymore because of side effects to a greater extent than patients are actually feeling as if they can't tolerate the therapy due to side effects. Now, some of that may be true, that patients maybe can't feel the fact that they have significant liver toxicities to a treatment, right? But I think most of the time it's not lab abnormalities that are driving this. It's probably, true side effects. A patient has an intolerable rash and keeps getting it every time they get a certain therapy that we are forced to stop that therapy. And that's just simply not happening that often with patients. So I do think there's opportunity for us to reevaluate why it is that we're altering therapies in patients, and of course the types of therapies that they're offering patients.
Another thing that came through on the survey was that with the issue of diagnosis and time to diagnosis is that, of course, many of the MDS patients presented initially with anemia, and then it was a question of how experienced their provider may have been, as Dr. Chandock noted in one of the slides, like the being aware of the possibility of MDS, and that it seemed like the initial diagnosis of anemia was either being attributed to age or just perhaps wasn't taken seriously enough. And how do providers deal with that concern?
It's a big concern, and I feel like our population or us as providers are overly sensitive to this, or like we should be. But I think in the real world, or in a larger population where general practitioners are seeing a lot of anemia, perhaps it's like desensitization over time, because like I said, there's such a over time, more than a third of patients will develop some sort of anemia, and just attributing that to age has become common practice, not just in the US, but there are large studies from Italy as well, and then other European consortiums where they're just not evaluated at all. They usually just say anemia, nothing to do, or prescribe iron. Now that works in a subset of patients, but like it was shocking to me that 40% of patients were essentially never evaluated. And then, like I mentioned, it was actually 16% on one study where they thought a patient had MDS or a bone marrow disease and then never moved forward with diagnosis. So that's like a very concerning population. And I think we need to do better. And a big part of that is education, because again, with these patients, there are many priorities. If they have 7 comorbidities, maybe 2 of the other ones are being, triaged. And the anemia basically just doesn't make the cut, but it can be one of the most important things that's driving all of the other problems.
Yeah, it's nicely stated, Namrata. I can't tell you how many times a patient has come to me eventually as a referral where initially they were told, well, your bone marrow is aging just like the rest of you, so it's just not producing as many cells. Now, that may be okay, right? A lot of these patients probably have a lower risk MDS where they don't have severe anemia needing an intervention. And even if we did diagnose them with myelodysplastic syndromes, it would probably be lower risk and not require an intervention. But for some of these folks, it may be an initial manifestation of a higher risk MDS where we do have to intervene. So we've seen these widely divergent numbers trying to figure out the prevalence of MDS in the United States. And they're so widely divergent because A, we don't have great methodology to capture how many patients are living with MDS. And B, there's just so much undiagnosed MDS out there that we eventually have to kind of shrug our shoulders and say, we just don't know. So the number of patients newly diagnosed with MDS in the United States is probably somewhere around 20,000. The number of people living with MDS could be anywhere from 60,000 to 150,000.
Thank you. We have no other questions coming in. So if you'd like to go on to your talk, Dr. Sekaras, or if you have any closing information about the low risk MDS before moving on.
No, I'm happy to move on. Maybe a reminder, Alice, to people about how they should submit questions.
Yes, they can submit the question. There is a Q&A option in the Attendee Hub screen that you're seeing, and you can submit questions that way, or through the chat. Either way is acceptable to submit questions to us.
Great, thank you. And I should have started this out. I apologize by saying there's an opportunity to ask questions after each of the individual presentations and during the panel discussion. So with that, I will share my screen. It's a pleasure to talk today about higher risk myelodysplastic syndromes. So I wanted to start off with how we define higher risk myelodysplastic syndromes, and Dr. Chandak actually just gave a wonderful overview of this. I'm going to start with the new pathologic classification schemes. Two of them were published within about a week of each other, and they don't quite agree. So this has led the entire MDS community to be up in arms about how exactly we're supposed to classify MDS. The first is the World Health Organization classification, which divides MDS now into MDS with defining genetic abnormalities and MDS that's morphologically defined. So if we're focusing on what would we call higher risk within the defining genetic abnormalities category, it would probably be those patients with biallelic TP53 abnormalities. I think we can all agree that tragically these folks don't live very long. And within the morphologically defined MDS, we would focus on those patients who have excess blasts, so 5 to 9% blasts or 10 to 19% blasts. And I would probably include in there some component of patients who have MDS with fibrosis, particularly those who have excess blasts. Now, the other classification scheme is the ICC, which echoes some of how the World Health Organization has divided MDS, but in other cases, it doesn't overlap, which is why we are all up in arms about this. So if we were to just use the ICC classification, we would say that MDS with excess blasts would count as higher risk MDS, and a new category of MDS overlapping with AML for those patients who have 10% or higher blasts, which looks like it's a tip of the hat towards redefining AML, instead of saying it's patients who have 20% blasts or higher, to start saying it's patients who have 10% blasts or higher. Why is this important? Well, this is a study that we've done through the National Heart, Lung, and Blood Institute National MDS Syndromes Natural History Study, which has been going on for some years now, where we are collecting information on patients with a suspected MDS diagnosis at the time they're about to undergo their initial bone marrow biopsy. And this was a sub-study we performed where we compared diagnoses of MDS from local pathologists, so wherever the patient was about to receive a diagnosis, to our two central pathologists who were experts in MDS. If those two central pathologists disagree, then their disagreement was adjudicated by a third expert pathologist. So very rigorous look at who had MDS and who didn't have MDS. And what we found in this study is that 73% of the time, a local pathologist would agree with the central pathologist about a diagnosis of MDS. So that's, if you're a glass half full sort of person, you'd say that's great. On the other hand, that means that 27% of the time there was disagreement between a local diagnosis of MDS and a central expert diagnosis of MDS. And we're not talking about disagreements that are subtle debates within pathology about whether a patient really had a 9% ring sideroblasts or 10% ring sideroblasts. This is differences between MDS and AML, or MDS and no cancer diagnosis at all. So I show these data to emphasize the fact that part of what we're talking about in this entire symposium is access to care and access to second opinions in care. And I think that is absolutely critical with MDS, where 1/4 of the time a person may be handed the wrong diagnosis. Now, you already saw from Dr. Chandak a discussion of the revised IPSS. This has become essentially our default staging system for MDS. And it's based, of course, on any kind of karyotypic abnormalities a patient has, relative degree and numbers of cytopenias, and the blast percentage. If we're just using the revised IPSS, we would say that patients who have a score that's greater than 3.5 would be in a higher risk category. Those with a score of 3.5 or lower would fall into a lower risk category. Now, just for purposes of this talk, I went to the original publication of the revised IPSS, and I went to the supplemental materials to look at the distribution of patients of different race and ethnicities who were included on the study. And this is all the information I could find. Absolutely nothing. I went through this exercise because Dr. Chandak and I recently wrote an editorial on the paper she showed with those heat maps of the United States about where people with MDS, with hematologic malignancies are located, and where it is that there are clinical trials available, pivotal clinical trials. And you could see that there were great discrepancies between those two. And in that editorial, we make the case that that just and equitable inclusion of patients has to start not just at the clinical trial point, but also as we're collecting information about karyotypic abnormalities, molecular abnormalities, inclusion in risk stratification schemes, particularly when it leads to a default staging system. So right off the bat, we don't have great information on race and ethnicity at the very basis for how we stratify risk in MDS. So moving on, I mentioned the discussion about mutations. Mutations in and of themselves can be a risk factor in MDS for truncated survival. If we're just focusing on molecular mutations, we would say that those at the top of this screen tend to be poor risk. These include some of the infamous bad actors like RAS mutations, TP53, RUNX1, ASXL1, etc. Now, these have recently been included in risk stratification schemes using artificial intelligence and machine learning approaches to more accurately risk stratify patients. In this one that came from our group when I was still in Cleveland, we included information on demographic data, clinical data, and genomic data about patients. Had a training cohort of almost 1,500 patients and a validation cohort of over 800 patients from the Moffitt Cancer Institute. They look to be fairly typical of patients with MDS. And once you enter all of this information in an online platform, this will spit out survival probability and leukemia-free probability at various months after a person is seen. And this could be at diagnosis, or this could be in medias res, in the middle of when a person is actually diagnosed with MDS and may have been living with MDS for 6 months, a year, 2 years, however long. So it's actually what's called a dynamic scheme. And I was embarrassed to see that once again, we didn't include any information on race or ethnicity in this machine learning approach. Now, the IPSS-M, which you also saw a reference to from Dr. Chandak, is another approach that's similar to what we published, looking at information that's clinical, pathologic, and molecular to risk stratify patients. You can see these nice divisions of survival curves in patients who had data that were entered onto this schema. And here it spits out scores similar to the online algorithm that we showed with our prognostic model. And similarly, there was no information provided in the original manuscript nor supplemental materials on race and ethnicity. So we don't know whether this is differentially accurate in people who come from different backgrounds. Let's move on to treatment now. Our treatment algorithm is a little more straightforward in higher risk MDS than it is in lower risk MDS because, I mean, to be honest, we don't have as many options for treatment. So a patient will come in with a higher risk MDS, and we'll divide them into those who receive a hypomethylating agent up front and continue on that hypomethylating agent, or those who receive a hypomethylating agent and then go on to receive a transplant. What's the basis for this? Well, this is the only prospective randomized trial we have shown a survival advantage for a therapy in higher risk MDS. Patients with higher risk MDS here were randomized to receive azacitidine versus conventional care regimens. 60% of those getting conventional care regimens got supportive care. The remainder got either low dose or higher dose chemotherapy. And you can see median overall survival of 24 months for those who got azacitidine and 15 months for those who received conventional care regimens. And that was a significant difference. These are data for decitabine, which aren't as impressive supporting decitabine, though there are a lot of problems with this study. Median survival for those receiving decitabine, 10 months versus 8.5 months for best supportive care. We do believe that these are basic design flaws that led to these conclusions versus the azacitidine conclusions, and we do think that it's acceptable to treat patients with higher risk MDS with decitabine up front. And here are data for oral decitabine cedazuridine. This study was a little more complicated. Folks were enrolled onto this. They could have Technically, lower risk MDS, intermediate 1 was included in this population. There were only 80 patients, and they were randomized to at first receive either oral or IV decitabine, and then they crossed over. So everyone got oral decitabine, everyone got IV decitabine. So you really can't make any comparisons about efficacy with this. What you could broadly do is say, well, the CR rate was 21%, the hematologic improvement rate was 7% plus 16%. That falls into around 35 to 40%, and that's about what we would expect for decitabine. And the median overall survival for this was around 18 months. That's about what we would expect for a mixed population of lower risk and higher risk MDS. So it seems kind of broadly as if it's comparable to the IV decitabine. This led to its FDA approval, which was based more on pharmacokinetic and pharmacodynamic data. And from all of these studies, here's the only information we have on race and ethnicity from the oral decitabine study, where you can see here that 93% of included patients were white, only 7.5% were Black or African American or classified as other. So woefully underrepresentative of our population in the United States, and only from one small study. Now, we also do offer transplantation to patients upfront with higher risk MDS. These are some of the most recent quality data supporting this recommendation. This is the CTN 1102, where patients underwent a biologic randomization to receive a transplant or not to receive a transplant. So it wasn't a formal randomized control trial. It was based purely on whether they had really an adequately matched donor in the eyes of the transplanter to undergo that transplant. This is not a direct comparison of transplant versus hypomethylating agents. As you can see, that patients who received a transplant, over 50% also received a hypomethylating agent. And for those who didn't receive a transplant, 42% did not receive a hypomethylating agent, which I think we would all consider to be the standard of care for those patients. So it does show an advantage for transplant in this study, but it wasn't truly a randomized study where patients got adequately treated on the control arm. So a major area of exploration in higher risk MDS has been to use combination therapies. This was a North American intergroup trial where patients with higher risk MDS were randomized to receive azacitidine, azacitidine plus lenalidomide, or azacitidine plus the histone deacetylase inhibitor vorinostat. Almost 280 patients were enrolled onto this study. You can see that adverse events here were pretty similar across the groups. Patients who received vorinostat had slightly higher rates of GI toxicity. Those who got lenalidomide had slightly higher rates of rash. But despite the relative comparability of side effects, significantly higher numbers of patients were taken off study or underwent non-protocol treatment modifications on the combination arms versus azacitidine. So this may reflect some of those provider biases that we discussed earlier in taking patients off of treatment or lowering that treatment because of perceived side effects. Now, the median treatment duration was shorter for those who got AZA and vorinostat at 20 weeks versus 25 weeks for azacitidine. This again is because patients were removed prematurely from the AZA and vorinostat arm, and actually from the AZA and lenalidomide arm. This did affect the overall response rates, which from a statistical perspective were no difference across the arms. There were some slight signals that overall response rate duration may be longer in the combination arms than in the monotherapy. Now, using some of the information from this study, we designed the azacitidine versus azacitidine pevonedistat trial in patients with higher risk MDS. Pevonedistat is a NET8 activating enzyme inhibitor. In this study, which was focused on patients with higher risk MDS and patients who had higher risk CMML or oligoblastic AML, we included a lot of language about not taking patients off study too early. We learned from the previous North American intergroup trial how we had to be strict about this, and we had to help guide providers. And this may be one approach to doing this, to include this sort of strict language, which, you know, fortunately or unfortunately, product labels don't actually include. When we looked at this study over time, unfortunately, there was no significant difference in event-free survival or overall survival, although we do see that hint of a 4-month difference that didn't reach significance. This study was not powered to show a difference in overall survival in these patients. One of the reasons that may have contributed to the fact that there wasn't an improvement in event-free or overall survival was the fact that the CR rate in the control arm was 32%. So it was like a full 14% higher than we had seen before with azacitidine monotherapy, probably because of the strict language keeping patients on drug for longer. So when we keep patients on drug for longer, they tend to do better with hypomethylating agent-based therapy. And you can see here, patients who remained on drugs for more than 3 cycles or for more than 6 cycles actually did have a significantly improved overall survival when they got the combination versus when they received the azacitidine monotherapy. Now, some other combinations that are being looked at in higher risk MDS, there's a combination of azacitidine plus venetoclax. Note that venetoclax is given over a 14-day period, not 28 days, as we would do in acute myeloid leukemia. In some of the very initial results that were presented on this, there was a CR rate that was 35%, hematologic improvement that was added on top of that at 24% for a total of 59% overall response rate. This is obviously better than what we would see for azacitidine monotherapy, which would be closer to 40%, but not uncommon in an earlier phase study with a highly selected patient group. There's also been a study, an early study of azacitidine combined with the anti-CD47 monoclonal antibody magrolimab. In this study, overall response rate was reported as very high. I focus on CR rates and hematologic improvement. When you do that, once again, this falls into about a 60% range, again, higher than azacitidine monotherapy, not uncommon in earlier phase studies of combination therapies. And there's a combination therapy looking at hypomethylating agents and sabatolimab, which is a immunotherapy, a checkpoint inhibitor. Once again, we have an overall response rate that's a little bit higher than we would expect for azacitidine monotherapy. I focus on these 3 early phase studies because these 3 will be reporting out from phase 3 data probably in 2024. So these are our next chance to have an FDA approval for the first time of combination therapy upfront in patients with higher risk MDS. And you can see in the sabatolimab data, and each of these studies has done this, there seems to be pretty high response rates and duration of response, regardless of cytogenetic risk or some molecular characteristics. They all show this, so we'll see if it's really true for a specific molecular subgroup. And here's all the information I could find on race and ethnicity in these combination trials. Absolutely nothing online. So when drug companies do submit data to the FDA for in a new drug application for potential FDA approval, they do need to submit comprehensive data on race and ethnicity, as much as they have hopefully collected accurately. But we're just simply not seeing this in the published literature. So to try to wrap all of this up, I do believe that our understanding of the biology of MDS, both lower and higher risk, is much greater than what we can do about it still. We do have a lot of drugs that are coming down the pipeline that may change that. Our classification of higher risk MDS is evolving, particularly as we have 2 new pathologic classification systems that muddy the waters. With treatment for higher risk MDS, we focus on response duration and overall survival. And what's key to that is keeping patients on treatment for as long as possible, at least 6 cycles, which is typically 6 months of therapy. And I recognize the paucity of data on classification and treatment in different populations, which is something that I really think we can have an active role in advocating for in journals. Certainly those of us who are reviewers should demand it in data that are submitted to a specific scientific journal for publication. So I want to thank everyone for listening today, our Leukemia MDS group at Sylvester and the University of Miami, and most of all, I want to thank our patients.
Thank you, Dr. Sagris. We do have one question that came in. Have there been any thoughts of creating an MDS registry for epidemiology analysis?
I love that question. I actually want to ask if that was planted by the National Heart, Lung, and Blood Institute. So when I showed the data earlier on the NHLBI pathologic findings, so local pathologist versus our expert central pathologist for the diagnosis of MDS. That is part of a really huge study through the NHLBI and the National Cancer Institute, where we're collecting information on 2,000 patients with a suspected diagnosis of MDS. Now, what we're finding in this study is that about half the patients actually don't have any kind of definable myeloid malignancy diagnosis or precursor to a myeloid malignancy diagnosis, but the other half do have definable either myelodysplastic syndrome, idiopathic cytopenia of undetermined significance, and within that, patients who have clonal cytopenia of undetermined significance, or what we're calling an at-risk population, patients who have molecular or karyotypic or abnormalities or enough dysplastic morphology that we think they're at high risk of eventually having the diagnosis of myelodysplastic syndrome or an overlap disorder, and we're following these folks longitudinally. So we collect a huge amount of data on these patients at baseline, including a variety of risk factors, everything you can imagine from factory work to Agent Orange exposure. We're also collecting detailed information on quality of life in these patients, and eventually we're following them and how they're treated over time.
And I understand that data, it will be open for researchers to access soon, or it already may be open, I believe.
So excellent question. We will be opening, so we're collecting all of this detailed clinical data on patients. We're also collecting data on their actual bone marrow biopsies, and all of that is computerized. So people will be able to actually get access to computer images of their bone marrow biopsies and aspirates. And we're collecting tissue samples on patients, both blood and bone marrow, but also we're collecting eyebrow hair. I know, which sounds macabre, but it's actually, there's a reason for it, and that's to actually be able to have a control in searching for germline mutations. So it's a tremendous resource. Next year, we're going to start to make available some of the tissue samples, and we're going to have a mechanism to submit letters of intent to do studies with the clinical data.
And with high risk MDS, another issue that our patients have reported to us has been the description of MDS in general as a cancer, low risk or high risk. But is that an impediment to the treatment for them or their perception of the seriousness of the disease? Do you think that's an issue?
Yeah, so it's another study that was conducted through the Aplastic Anemia and MDS Foundation. I love this study also. And as you're designing a questionnaire, there are certain things that you want to get out of that questionnaire. And sometimes you'll include almost like toggle questions or pivot questions as you go from one category to another to get people thinking about a different set of questions. And sometimes those kind of what you consider to be almost a toggle or throwaway question are the most important question that you ask in the entire survey. In this case, we asked a question about how MDS was first described to a person, and only 6 or 7% said the MDS was ever described to them as being a cancer or something that could lead to leukemia. So over 90% of the time, people were told that they had a blood disorder or a bone marrow disorder, or what we talked about earlier, something that was a normal consequence of aging. So it gets, Alice, to kind of a broader discussion about the access to care that people have and whether they're able to get to a specialist either primarily or as a second opinion to clarify the seriousness of MDS and to define the treatment options, and in particular to get access to clinical trials. Because as you saw between Dr. Chandok's presentation and my own, we don't have a lot of tools in our toolbox for treating MDS. So one approach that we will often take is if a clinical trial is available to offer it to our patients, knowing that the few tools that we have already been FDA approved, they'll always be available to a person, but the clinical trial won't always be available.
Thank you. I'm checking, we don't have any other questions coming through. Actually, this is just a follow-up to the question about the MDS registry. The question was not planted, but it's a pediatric hemonc physician that had asked the question.
Great. No, thank you. It's a super question. It's going to be an incredible resource. I can't emphasize that enough. So once it becomes open to researchers, please submit LOIs and take advantage of it. It's really cool stuff.
Well, since there are no other questions, we can move ahead to the panel discussion. I believe our discussants are with us or will be momentarily.
What I would like to do then is welcome our panel discussants to talk about addressing gaps in serving patients who have MDS. We have Dr., and I apologize if I pronounce your name wrong, please correct me, Dr. Arun Khan, who's an associate professor at University of Illinois, and Dr. Leila Shun, who's an associate professor in the Division of Hematologic Malignancies and Cellular Therapeutics at the University of Kansas Medical Center. How are you today?
Wonderful. Thank you so much, Dr. Zacharias. Glad to be here.
Thank you for coming today. It's great. And also, as we're talking, if folks want to send in questions to Alice, please do so. And then Alice, just maybe kind of make us aware when there's a question that's waiting and we have an opportunity to answer it. So I want to maybe kick us off by presenting a fact, and then I'll ask a question of all of you. And please, this is supposed to be bi-directional. So I guess I'm technically moderating this, but I don't have to be the one asking all the questions. I encourage all of you to ask questions of each of us and to be challenging in those questions to get us to think about this at a deep level. So I looked up the SEER statistics, Surveillance, Epidemiology, and End Results Program, which is a collaboration between the CDC and the National Cancer Institute to track data about cancer across the country. And I saw that MDS is diagnosed in 5.4 per 100,000 men and 2.9 per 100,000 women in the US yearly. Rates increase with age, as you heard from Dr. Chandak. And they rise from that, the 5.4 and the 2.9 average out to around 4 per 100,000. They rise to 14 per 100,000 in people 65 to 74 years old and 42 per 100,000 in those over the age of 75. Rates in Blacks is 3.2 per 100,000, whites is 4.2 per 100,000, and Hispanics, which is a majority population for me and Dr. Chandak down here in South Florida, is 2.9 per 100,000. So at least according to SEER, and we can all debate the accuracy of SEER and whether it's truly representative of the United States. There are some papers out there about how SEER does oversample certain populations, but this is what we got. These are probably the best data we have in the US. We do have some discrepancies in men versus women, in by different age, in people of different racial and ethnic backgrounds. So I'm curious, could you describe a typical MDS patient where you practice? Since we all practice in different areas of the country, maybe I'll start with Dr. Shun.
Okay. Thank you so much, Dr. Zacharias. So in Kansas, we have a large population of rural patients, coming from Topeka, Wichita, Salina. So the patient that we see in our MDS clinic have traveled a long distance to meet with us. So that's only it's an iceberg. The bulk of the patients we don't get to see because they're cared for in their communities. And we offer the typical, tertiary care, high-risk patient, as I cited in a couple of cycles, and then looking for the donor, preparing for the transplant. So we first of all don't see the bulk of our patients, unfortunately, just due to the layout of our state. The patient I see in the clinic is an older patient who, for the most part, doesn't understand the severity of their illness because at the time they feel okay, they're getting transfusions. So it's an opportunity for education. It's an opportunity to offer them clinical trials. And that's an area of in-depth effort to make clinical trials more accessible to the patients, and also looking for that donor and preparing for the transplant for the high-risk cohort. So more rural population, I would say. We also live in a city which has a substantial population of African Americans, and we collaborate with our colleagues in our community hospital, and we do get to see a good number of African American patients with MDS.
So when you say travel a long distance, you may or may not know, I lived in Cleveland for 18 years, and I realized that traveling a long distance was very different in Cleveland than how I defined it in the Northeast. So in Cleveland, someone travels a long distance, they might drive, 5 or 6 hours from nearby Kentucky or West Virginia to come see me. Here in South Florida, I'm realizing that long distance is anything that's more than half an hour on I-95 to get to Miami from anywhere that's north of Miami or south of Miami. So what is a long distance in Kansas?
6 hours, 5 hours. That's what it is. Our colleagues in our cities will send us the patients, and patients will be like, I can come here for your clinical trial. Impossible. Because exactly. So it's that long distance, yeah.
So 5 or 6 hours they'll drive to come see you.
Yes.
That's incredible for folks who are on a coast. That's an incredible amount of time. That's amazing.
Yeah.
Okay, so move on to Dr. Khan. Could you remind everyone where you're from and what a typical patient in your clinic with MDS looks like,
Yes.
or comes from, their background?
Yeah, absolutely. So I work at the University of Illinois, Chicago, which is a minority serving cancer center in the city. So our patient population is really the catchment area around us, which we serve, which encompasses largely South and West Chicago. So our MDS population is largely, within sort of the city radius of, I would say, within 10 miles easily. Is, I would say, about a third is non-Hispanic Black, and a little less than a third is Hispanic. We also have a mix of some Asian patients because we have a presence in the Chinatown area. So our referral pattern is really our University of Illinois Miles Square network of clinics, which is federally qualified healthcare centers. So it's usually patients that are found to have cytopenias and are worked up and are sort of sent to hematology clinic. There's a small portion that are sent by other practices, again, sort of further flung in rural Illinois. And those are more high-risk patients who oftentimes have already received first-line treatment or are undergoing evaluation for either a trial or a transplant. But I would say that's the rarer population. And then in terms of the typical patient, I would say that the typical population of an MDS patient that I see would be somebody who's advanced in age, like you stated, but really a lot of times, because these patients are often from disadvantaged backgrounds, there's a lot of comorbidities that they present with. And oftentimes we're kind of dealing with sort of, a little bit of heart failure, maybe borderline kidney function. And even for the low risk MDS, that really can lead to this cycle of, transfusion, fluid overload, and sort of that kind of thing where, I think alternates to transfusion are really important. And you kind of wonder about the effects of iron overload in these patients that have pre-existing cardiac issues. So I think that a lot of what we do is kind of for the low risk patients, like you stated, supportive care in whatever form we can give. Patients are always, of course, more willing to get ESAs and sort of low intensity treatments that don't require as much monitoring. Trying to put patients on study is hard, is challenging. But having said that, after HMA progression, there isn't a lot that they have out there. So trials start to become one of the few remaining options if they're not transplant eligible. And definitely for patients who oftentimes are care providers for grandchildren, sometimes have, special needs children at home and don't have the infrastructure that they need to be able to help them do all the visits. We have to liaise very closely with social work and have innovative ways to try and all our trial patients get free Uber rides and things like that to come back and forth to get the testing done and try and stay as compliant as possible.
So if I'm summarizing what I just heard you say, and please correct me if I'm wrong, you serve mainly an urban population that's for the most part within a confined radius. So for example, my uncle used to live in DeKalb, Illinois, which was corn country and probably about an hour and a half out of the city. You're probably not seeing people from DeKalb as often as you're seeing people from Chicago proper, right?
Correct.
Okay,
Yes.
so your challenges aren't that people have to travel 5 or 6 hours, like with Dr. Shun.
Right. Correct.
It's more access to care, follow-up, making sure they are able to get back and forth from the treatment center.
Correct.
Correct? Okay.
Yes, that's right.
So, Dr. Chandak, can you describe our patient population here in South Florida?
Absolutely. So my typical clinic, and I can give you some cancer center specific demographics, but my particular clinic is primarily all Spanish speaking. So of 20 some patients, about 16 are Spanish speaking. Our South Florida population is very Hispanic heavy. And in our cancer center at University of Miami, we see more than half of our patients are Hispanic. We also partner with Jackson Memorial Hospital, where a lot of the patients are uninsured and immigrants from Central America as well as Cuba and alike. Many of them undocumented, some without any form of insurance. So there are multi-levels of challenges depending on which site, for the insured patient, who's, Hispanic and a non-English speaker, just making sure that we are communicating our message appropriately. While the distances are nothing, like have been previously mentioned, the 6-hour ride is not a frequent thing. We are also the only big academic center in South Florida, or so people do come 3-4 hours looking for trials, and then actually talking through the trial sometimes becomes big logistical conversations. Then when we're accruing on trials, or for the patients who are interested and we want to make sure that every patient has a Spanish consent form, a Spanish interpreter when necessary, to fully understand everything that's going on. When it comes to more the uninsured population at our partner hospital, there are many, many barriers to care. And I think, while we do what I would call an exceptional job, getting therapies approved is often a challenge, particularly more expensive therapies beyond the ESAs, luspatercept or approved therapies are more of a challenge. So insurance battles in that situation, or finding them some sort of funding for that. And we've formed great partnerships, but it's not a perfect system. So I think those are the primary things I think about when I think about your typical patient.
Wow, I'm kind of blown away by the differences in our practices, right? Just like we say, MDS is an incredibly heterogeneous diagnosis, where there isn't one size fits all. There's clearly not one size fits all for how we would overcome some of these obstacles. I'm curious, I want to circle back to Dr. Khan. You had mentioned that you have patients who are Spanish speaking as well. How do you navigate that? Or do you yourself speak Spanish? And I will say I do not, although I can grunt my way through a physical exam. I can't have a meaningful conversation with somebody who's Spanish speaking only. So I always have someone around me who's bilingual.
Right. Yeah, no, I'm probably similar to you in my fluency. So I usually, we have the audiovisual interpreters, but generally, I mean, we're kind of fortunate. I think a lot of our fellows are oftentimes bilingual, but it always helps, you're right. And especially for discussions where, it's a change of, a change of disease or discussion about a trial, or even just explaining what the disease is. I like to have an in-person interpreter, and definitely shy away from using the family because, there's a little bit of filtering that happens. And I think that, with that, obviously it's not perfect. I think that's one area where clinical trials definitely need some work, because a lot of times we open studies and sponsors are blown away by the number of different languages we need the consents in. And, there's like this short form consent, but that's really nothing. We need the whole consent in another language. And I think that's something we need to sort of continue to push for. And similarly, these patient reported outcomes, I've had patients on study where I've given them this e-diary only to realize it's in English, and the patient and no one in their family speaks English. So I think just sort of being continually aware of that, because, these patients need to be represented.
Nicely stated. Yeah, we have the phenomenon. We say the typical patient of ours is Spanish speaking only, but the kids are there and the kids are always bilingual. But you're right. There's a different level of communication with family doing it versus someone who's, want to say, probably impartial or not as emotionally invested in it. So, Dr. Shun, how do you? I'm curious. Could you paint a picture of it? There's no one typical patient with MDS, but maybe kind of the sort of patient you see in Kansas and what obstacles that person faces.
Thank you. So a patient who is referred to us with high-risk MDS, let me pick the worst case, right? So already received a few cycles of AZA with a local physician. Because I work in the transplant center also. So the initial visit is you have a high-risk illness, high risk of transforming to AML, risk of dying. The other is just a placeholder. This will not work forever. We'll define your donor. So that process has to be undertaken. And then I send the patient back home to the physician while I work on the donor search. Once I have a donor identified, I bring the patient back. And in a typical meeting, I'll have a social worker, financial coordinator, try to help me get them a room at the Hope Lodge. This is American Cancer Society run Hope Lodge. Get them there so we can prepare for the transplant. So for the high-risk patient who has a donor, fortunately, with the haploidentical transplant, we can have more access to donors. We participated in the BMTCTN 1102, and contributed there. And we do believe that transplant in the high-risk population definitely has an advantage. So that's what we do. If unfortunately the patient is already refractory and is progressing, I partner with my colleagues here at the Cancer Center to enroll them on clinical trials. We do have the magrolimab trial open. We do have the venetoclax, combination. So we get them on combination trials to see if we could improve their disease status before we go on to transplant. Sometimes the cat's out of the bag, it's AML, right? We have to admit them for intensive chemotherapy, sort that out. And then, so for patients, it can be overwhelming. Really, it can be. These are hardworking farmers out there in rural Kansas. Suddenly they have to come up here, deal with logistics, staying up here for 100 days, full-time caregiver is not a joke. I really empathize with families dealing with high-risk MDS.
So for some of your farmers, I treated a lot of farmers also when I was in Ohio. What was the impact of some of these therapies on their ability to run their family business, to farm?
Sometimes they have to give it up. If it's the harvest season, you have to be on the combine 10 hours. Somebody who's dealing with transfusions, chemotherapy is extremely exhausted. And what has happened typically is the young people have left, right? It's elderly people who run the farms. And when they are afflicted by MDS, I've seen them need to give away the farm or sell the farm to concentrate on their own illness. So it's a huge effect on them. I look forward to the day when we can have better therapies for MDS that can be given to the patient in the community that they live in to allow them to resume their lives, because I feel that an MDS diagnosis, essentially, even if they are cured eventually through a transplant, has dramatically shifted their trajectory, their life completely changes.
I once gave a talk in Australia, and most of Australia is extremely rural and spread out. And I remember they had developed programs to administer hypomethylating agents in people's homes, because there was no way those people could make it to a cancer center regularly for a daily shot. So they had visiting nurses who were able to do that and somehow, reconstitute the azacitidine there on site and give it. And I wonder if that's an approach we should consider in rural areas.
That's something that, so the National Cancer Institute is funding a project through the ETCTN, and they're funding that quite a bit to try and help rural zip codes access clinical trials. This is something we participate in here at Kansas and have been successful in connecting with our colleagues in the community and telling them about what trials we have for them and making it so that it's easier that people can go back and forth, with some funding. But I think the Australians have taken the cake. I mean, take it to their home, right?
So I'd
That
be
is
curious to
amazing.
know,
Yeah.
actually from you,
Yeah.
the distance things like we were mentioning are a whole different dimension for you. And a lot of studies have, particular time points like PKs and things like that, which you need them to be there for 12 hours, 15 hours. And if they're driving 6 hours each way,
Yeah.
that's untenable.
They have to
It's not,
stay. They
yeah.
have to stay with us,
So,
Dr. Chaddock. They have to stay at the Hop Lodge. That's where they're
oh,
hosted.
okay.
They have
So
to
that's
stay
like
for
readily
multiple
open
days.
to everyone.
Yes, yes, we're very lucky.
That's great.
American Cancer Society has a big Hop Lodge in Kansas City. And this is for all cancers, right? Every cancer, breast cancer, colon cancer, because they anticipate patients have to travel quite a bit of distance to access care at a tertiary center.
So that's something, in a much smaller scale we experience here because patients just tell you, I can't do 3 hours each way, that's it. And then, for some you can get hotel stays or some, other housing accommodation, but for some, it's just not an option. So different kind of reality.
Yeah, absolutely.
I had a quick question for Dr. Chanaya and Dr. Chanak, actually. Do you, in terms of, starting patients on treatment and trying to keep them, one of the things I struggle with is kind of the lab monitoring. And I feel like a lot of our patients who have, the sort of managed care plans, in terms of sort of the softer things we need, like home labs, even something as straightforward as someone going to your house and drawing your blood, we rarely have access to that because some insurances require, you have to have X number of miles to the nearest medical center. And having trained at a different place, I was really shocked by the fact that, that kind of supportive care can really vary depending on the provider. So how does that work for you?
So just general supportive care. So I rely and work very, very closely with our social worker, to be honest, because there are so many of these factors, just like you mentioned, care that's just not covered, finding alternative providers, just their insurance being valid only in certain sites. And then also just education, I guess, around all of these issues, because when you're saying, transfusion or schedules or labs, it's kind of a lot for a patient who's just starting care to get their head around that. So I think it's just, medicine is a team sport and just trying to engage as many folks at the center as you can. Dr. Secker knows this very well, but I am a loudmouth and just call everyone. But for only some patients is that successful. So you're right, it's definitely a barrier, but it's just something, you just make the best of what I would not call a less than ideal situation with the resources that we have. Unfortunately, I think we have more than many places. So that's something I think on a larger scale that we need to address.
I think partnering with folks in the community is so critical with this. And, it has a lot of, I think, beneficial downstream effects. So I know that some of our community providers are sensitive to if a patient comes to the university, they stay at the university and then they lose that relationship with the patient. They may have had that relationship for years. So we really try to establish that partnership at the very beginning and encourage patients to maintain their contact with their primary physician. And it's usually an easier way that they can get transfusions. And we try to keep an open dialogue, particularly when a patient is on a clinical trial, and we have to make sure that there aren't those deviations to trials.
Right.
How, so with some of your patients, Dr. Khan, how do you overcome the obstacles that you just identified?
So I mean, I think as far as the labs, I often like hit a wall, but trying to kind of minimize where we can. And again, like you said, if they have another community oncologist, but because of our catchment, most of them their sort of medical home is UIC. So we do have to just keep bringing them in as needed. We have subsidized residents, like Dr. Shina kind of mentioned, for patients who are there for the longer term, or somebody needs, for example, like PKs and needs to stay a night, or somebody's coming from Peoria and they take the 4 a.m. train. Then we have to set all of that up in advance, and so having a well-staffed kind of social support network in clinic, I think, is very key. Another area, which is more, I guess, a question than an answer, is that at least, in the AML world, where we've been looking a little bit at disparities, it's kind of interesting that approaches to end of life conversations also actually are very different, or sort of differently conducted, I guess, based on a patient's background. So I was just curious if, since we all see kind of different patients, whether there are different approaches, or sort of engaging with the family at different levels to when that time comes for that discussion.
I can start just talking a little bit. Yeah, I was like, so I'll say this. I'm fortunate that I do speak Spanish, so I can communicate with most of my patients about most of their medical issues. But speaking Spanish is not the same as having an end-of-life conversation in Spanish, because it is not my first language. I don't have the same subtlety I might have when explaining treatment or things like that. And these are big decisions, right? And very, very culturally specific. So what I believe about, end of life, or, my take on what I would do in this situation is different from my patient. And I need to be able to communicate clearly enough, but also make sure all the facts are there so they can make their own decision. And that's hard. With interpreter services, it's just not the same. Like, I know there's very little we can do about this. And like I said, it's fortunate that I can at least talk to them, but there's this level of finesse that's definitely lost. And that makes a difference in what decisions the patient actually makes, and if they fully understood it, or they were able to reflect on it as well. Sometimes I think just starting with what they already know and have them say things back to me or tell me what they feel is a starting point that I use, as opposed to just telling them, well, the prognosis is XYZ, because we always tell our patients that this is what happens in all of the patients, but MDS is such a diverse disease that it's not the same for everyone. So kind of trying to suss out their views on these key topics first, before actually giving them the whole conversation about this is how things might look, is my general approach. It's not perfect. It's just what we do.
Absolutely.
Can you speak a little bit without, obviously we want to avoid anything that's a generalization about any culture, but have you noticed any cultural differences in approaches to end of life that you've learned in how you have this discussion?
I think definitely there are some cultures where I would say, and I think you get a sense of this because fortunately we do have these longitudinal relationships, so we kind of get to understand the dynamics of our patients. But I think some cultures defer very much to the younger generation to sort of make the decisions. In some cases, some cultures, it's more sort of, if there's a spouse involved and, there's sometimes, they lean toward the male gender to make some of the decisions. So you definitely have to kind of suss out how, like you said, Dr. Shankar, how that family works. And I think you're absolutely right, kind of just having open dialogue and kind of, seeing who's the more, kind of like guiding the decision making as you kind of treat these patients is important. I think the hardest thing is often like the whole transfusion support, and that, you know, when you sort of make that decision for hospice, I find that's always a very difficult conversation about blood products. But yeah, no, I think I absolutely agree with you.
I think the one thing in our population though is the one conversation I have sort of universally is like, make sure that everyone that has a decision-making role in that process, I'll always ask the patient, is everyone you want at this meeting here? And if not, we're, you know, the one great thing that came out of COVID was the fact that we can get as many people on the phone, have a big Zoom meeting, have all of the partners involved and have all of their conversations, you know, as a part of that meeting. So just getting all the shareholders in the meeting to avoid issues at the end of life. You know, discrepancies in opinion between siblings or the spouse or, you know, whoever may be involved.
So very good point. So I deal with patients who have post transplant relapse, which is a whole kettle of hell, you know, because the counts are super low. Patients are already beat up. In those conversations, I bring in our palliative care consultants who are embedded in our clinic. Fortunately, they have nurse practitioners who can come along with us. Most patients would like to get transfusion, to be honest with you. They would be okay with hospice if they can get transfusion. It's just the lack of transfusion shocks them because every time they get a blood product, they feel better. They do, you know, and the whole idea of hospice is to feel good and, you know, so that is very challenging for us to convince somebody to go onto hospice. So what we do, it's a graded process. Best supportive care in our clinic, as long as they feel okay. And then one day something happens, we already have the hospice house selected, the agency already set in place, then they transition to hospice at that time. We try to avoid admissions and try to do IV antibiotics in the clinic as much as possible in the clinic. Yeah.
These have been great reflections. I wanted to switch gears a little bit and ask about, you know, both Dr. Chandak and I talked about molecular testing, right? Which we all would acknowledge as kind of a standard of how we approach patients with MDS to really give them the most accurate diagnosis and even start to think about referrals for more aggressive therapy like transplant. How does molecular testing affect your patients? So is that something everyone has access to? Is it state by state? Is it insurance plan by insurance plan? And do they have the same access to molecular testing that everyone else does?
So it depends on what, so we have an NGS panel for 141 genes, which is in-house. So that is something we can do. Now, patients are coming from Salina, Topeka, ways off. They don't have the NGS report. Guess what? I repeat bone marrow biopsy in the clinic. Most patients are okay with that, willing to undergo that kind of procedure. But since we have it in-house, we can get that sorted out for them. Yeah, I don't know about other places.
So we don't have it in-house, and I think for AML it's straightforward because they have a cancer diagnosis. But if it's a cytopenia and we're doing the marrow and I want everything on the marrow, a lot of times, so I have to apply for insurance approval prior to sending it, because I have had patients call me with this $3,000 bill and they don't know what to do with it. And that's a whole, you know, very unpleasant road. So and sometimes after 2 weeks, I find out that, oh yeah, insurance denied it because there's no cancer diagnosis, there's no dysplasia, cytopenia is not an indication. And so I oftentimes have to do the marrow, figure it out, and then you know, work off of the blood. But and even then sometimes MDS doesn't get covered, like they want a cancer diagnosis to cover NGS. So, and again, I think this very much insurance plan driven, but I think that playing field is not yet level for sure for us.
Well, I want to, oh, we have one question. And I think it may be more germane for Dr. DeCastro's presentation, so I'm going to hold off on that. But I did want to thank all of you for participating in this truly enjoyable panel discussion. I feel like we could go on for another 2 hours. and troubleshoot the very different patient populations that we see with MDS. It's so eye-opening to hear about the perspectives from different areas of the country. So thank you all for participating, and I'll ask everyone who's listening in to stay with us now for an update on the diagnosis and management of aplastic anemia and PNH with Dr. Carlos de Castro from Duke University.